Now on to C. diff. So C. diff is a organism. It's gram positive, right? So it's gram positive, and it likes to grow. It will proliferate, especially in the large bowel, right? That's usually where it hangs out. A lot of people have it, and how do you know you have C. diff? Well, if you have diarrhea, you could have it, but it's usually with recent antibiotic use, right? They have recent antibiotic use. Which ones? Ones that are going to eliminate everything. So broad spectrum stuff. All right. So over here you got Zosyn. Everybody's on Zosyn, right? And fluoroquinolones are high on the list. They're like second place. First place is clindamycin. So clindamycin is usually reserved only for specific situations, usually for like toxin-forming bacteria, if they have like a necrotizing fasciitis or something. But clindamycin is like number one, right? There's number one. And then we have number two is like fluoroquinolones. And number three is our beta-lactams, right? So beta-lactams are what again? Those are your cephalosporins, right, which have 5 generations, and then we have penicillins, and then we have what's another one that we use commonly? It's like a tank. It's gonna knock out any kind of sepsis. That's carbapenems, and that makes sense, right? We got carbapenems, we got penicillins, piperacillin, tazobactam, and we got our cephalosporins. So it's 1, 2, and 3. Those are our top 3 list for causing C. diff, and it makes sense. They are going to be knocking out our gram positives and gram negatives. And well, did it knock out the gram positives? It might have, but it's usually the gram negatives that are being eliminated, so that then the C. diff can then proliferate and grow to a point where it can start taking hold in the bowel. So C. diff will then grow, it'll start proliferating, and it's going to start forming a pseudomembrane, a little green membrane over the bowel, and therefore water is going to get absorbed or not absorbed. It's going to get not absorbed. It's going to just bounce right off because it doesn't get absorbed, right, into the GI, into the bloodstream anymore. It gets that process shuts down, or doesn't shut down, but doesn't work anymore, and therefore we get watery diarrhea. It might be watery diarrhea that is green and mucoid as well, right? So C. diff will do this, and then yes, it takes hold, but what makes it painful is it's going to start secreting all kinds of toxins, right? We've got toxin A and toxin B. All these C. diff toxins are going to they're going to lead to a lot more colitis, a lot more inflammation, right? And then the C. diff itself can start procreating and start growing exponentially, and you got to stop it somehow. So we have other antibiotics we can give to shut down C. diff. Okay, and we can detect these toxins on lab screen, right? We can detect C. diff toxin A or toxin B. Just depends whatever lab you're at. Okay, and then the other piece that makes C. diff very, very virulent is the formation of spores. So that's what makes it so that it can spread. It's its own, survival mechanism that it can use, right? It's going to produce all these toxins and take hold, but it also produces spores for the future, right? So someone else can be lucky enough to pick up an apple at Walmart and just eat it right off the shelf, right? Because the person before them had C. diff and it just came from the Walmart bathroom, and they touched the apples in detail, and then you were on a Protonix, right? You were on pantoprazole because you had you had GERD, and then now it made its way through your high pH gastrum and made its way to your colon. Now, congratulations, you're gonna have C. diff. All right. So how do you know you have C. diff? You're gonna have a temperature, right? The temperature is gonna be going up because it's starting to take hold. You're going to definitely have that diarrhea. The water diarrhea there with abdominal cramping is going to happen because of that spore that you intook from Walmart, right? Or Target or whatever store you like to frequent, right? So C. diff knows no bounds. It's not bougie. Anyways, how do you kill spores, right? What's the way to kill a spore? Antifungal? No. Anti what? Something antibacterial, of course. All right, so it could be something, but so basically the answer is not hand sanitizer, not 70% alcohol, not 80% alcohol, not 60% alcohol. Back in COVID times, made sure that everything was 70% or more. Before I just trust, it's hand sanitizer. Okay, cool. It has to be 70% or higher to kill the important stuff. But the important stuff does not include C. diff. C. diff is immune. The spores are immune to alcohol, right? They are resistant to alcohol. They are not resistant though to their spores get disrupted by soap and water, right? So soap and water is going to, well, not the water, but the soap is going to get rid of your spores, right? And so will this thing right here, the yellow top, is not formula, but the brand we use. What's this for? What's yellow mean? It's bleach, right? What does gray mean? What does purple mean? Purple's like acetone, but the purple, the gray don't get rid of C. diff. If you look on the side, there's like 75 different bacteria kills. C. diff's not on there. She just tell me what it doesn't kill. I don't care what it does kill. I want to know what it doesn't kill, right? So bleach will kill everything, right? But we only use it and also kill all the keys on your keyboard. Makes it really fun. Hey, can you witness for me? It's like, oh, you don't know your homebro, do you? Right? So ASDFJKL semicolon. Anyways, you have it. There's bleach will ruin not only keyboards but also medical devices. So we have to be, we use it sparingly. But if you have a C. diff patient, they're in C. diff isolation and everything has to use bleach, right? We have to indicate not to use the hand sanitizer when we're going in and out of the room. All right, so soap and water is what we're doing there. We got PPE in place, right? Up to 40% of the patients that get C. diff, they're gonna have C. diff again, right? It's not something that's easily eliminated. So it's like a flip of the coin where they're gonna have C. diff again in 3 to 4 weeks, all right? And C. diff is not fun. Yes, it's painful. You get febrile. You have to be admitted to the hospital. It's not a fun thing to have. Okay, it can lead to hypotension, acute kidney injury if you do lose a significant amount of fluid. And you can have patients admitted with C. diff colitis, and that could be the reason for their septic shock. Okay, diarrhea being a key symptom of it. Also, one of the complications, those spores get all the way down to the enteral nervous system, which is right there, right above the blood vessels, and it can just knock it out. So then you form a ileus right there where the C. diff has taken hold, and then that enteral nervous system does not work anymore, right? There's no more nerve activity in this area right here. So what happens? Peristalsis halts right there, right? Before it's going to start doing its thing, but right at that section it's not. So you get a toxic megacolon. So you can see this is an example of a toxic megacolon. It's greater than 10 centimeters. That technically is a toxic megacolon, right? Where you look at the CT scan, X-ray maybe, but the CT scan shows you that the bowel is more than 10 centimeters dilated. That's megacolon. And then you can kind of rule it out and say, well, shoot, they have C. diff. That might be a complication from that. There are other genetic reasons for it, why you would have the nerves being knocked out here. All right, but most commonly in the hospital setting and a medical ICU, it's going to be due to C. diff. Okay, so you see this X-ray right there. That's a huge bowel. Look how big that guy is. Okay, that's a surgery that they did afterwards. And another significant thing is it costs a lot of money when you have C. diffs, 3 times the cost of a normal stay when you get C. diff. So it's not only for the patient, but it's also America-wide, US-wide, it's a significant increase in costs. So if we can eliminate the overuse of antibiotics, that'd be ideal. We make sure that if they got antibiotics before, that we're alert to it, and if they do have C. diff, that we isolate and eradicate it as much as possible. All right, so does your patient have abdominal infection? So like I said, I forget the stats, but it's up to like 3 billion of the world population has C. diff now, right? So it's up to like 20 to 40% of us in this room, we have C. diff. Congratulations, right? So do you test everybody for C. diff toxin? No, because then you give everybody antibiotics, right? And one of the antibiotics we give them is metronidazole. Metronidazole covers anaerobes, which grow in the GI tract, and then it actually induces C. diff. So that's not a great thing to do. Okay, so we want to make sure that we are testing people appropriately, and we make sure we are looking for those that are high risk, right? That do need C. diff treatment and that do need C. diff testing. So C. diff testing we'll talk on the next slide. But how do you know someone has C. diff? They got the fever because that C. diff has taken hold in the GI tract. It starts irritating the GI tract. That's going to make my GI tract irritated, right? It's going to make me start getting some infectious process throughout my body, and that's going to make me have a fever, right? And that's going to make my infection alert system go off, right? My little life alert, and that's going to make a white blood cell count start going up, greater than 15 usually. Right? Usually when you have an SNS response, your white count automatically goes up to like 16. That's just automatic, right? If you ask out your girlfriend and was really, really nervous and you guys started running, I don't know what happened. Anyways, what's going to happen is your white count can go up just because of an SNS response. That's perfectly normal. But when you have an infection happening, that's going to cause a white count that's greater than 16 usually. All right, and then if your white count is more than 40, it's always GI until proven otherwise, right? Because that means that all this has been destroyed, this membrane right here has been destroyed, and these guys can just straight up go right across and really cause an immune response to occur. So when you have a white blood cell count that's more than 35, 40K, you're always saying, well, is it C. diff? because that's a very, very common infection that can occur, right? Or they could have another infectious cause of their in their GI tract, right? They could have ischemic colitis, which doesn't present with diarrhea. What does ischemic colitis present with? Not infectious colitis, which is this. It's ischemic colitis we talked about with GI what? GI bleeds, right? Mesenteric ischemia causes disproportionate pain, but they both, mesenteric ischemia and ischemic colitis, cause a GI bleed, right? So those things, you can put you at risk for your the gut that didn't get perfused. It can then now be at risk for bacteria proliferation, right? And then the bacteria go across the membrane, across the GI tract, and translocate into the bloodstream, and your white count's going to shoot up greater than 40K. Okay, obviously they'll probably be febrile as well. The other reason why your white count just in general might be more than 40K is you have some kind of white blood cell cancer. You have a leukemia or lymphoma, something that's another good reason for why a white count would be high, right? So if you say, oh, you have no belly pain, nothing GI going on, CT item is negative, it might be some kind of cancer. We got to figure this out, right? But if they have a fever, they got abdominal pain, bloating, diarrhea, all these things that are pointing towards the bowels, and the white count's elevated, they got a fever, these things are telling us we have something CDiffy. Okay, so are they high risk for C. diff infection? Who's high risk for C. diff infection?
Chronic hospital stay.
So they got hospitalized recently, right? They got exposed to something in the hospital, right? So people like to what's the word? Not audit. They like to appeal their hospital discharge, and they want to stay another 2 days, 3 days, 4 days. It's like, are you sure? All right. So you get a lot of hospital-acquired infections. We're going to do our best, but there's a high risk you're going to get it, right? Same thing in the ICU. So the nursing care is so much better here. It's 1 to 2. I get my call answered right away, right? But they are high risk of, ICU-associated hospital-acquired infections and hospital-acquired conditions, right? We don't mobilize as well as we might do on the floor, right? Just something as simple as the physical therapist, they round on the 3rd floor before they round the ICU, and they might run out of time just in their shift. And we'll get them tomorrow, right? So it's better to be on a floor that specializes in more active care, right? Not that the ICU is not an inactive place. So yeah, being exposed to healthcare, but also being exposed to what? Antimicrobials. What were our top 3? Top 1 was clindamycin, then your fluoroquinolones, and then your beta-lactams, right? Beta-lactams, which had 3 varieties. You had your cephalosporins, your penicillins, and the last one, the strongest one, is your carbapenems. It's going to knock out everything, but C. diff is going to take hold. Okay. Is there other way to explain the diarrhea? There's nothing. Are they on lactulose? Well, shoot. That's why they have more than 3 stools per day, right? So that could be the reason. So they got, it could be antibiotic exposure. There could be a good reason, right? So here's the clindamycin, number 1, right? Fluoroquinolones, number 2, and then we move on from there. All right, so host factors, they're immunosuppressed. They're already having a weak immune system, puts them at high risk for developing C. diff. Okay, chemotherapy annihilates the GI tract, easy for infection to take hold. Right? And like we mentioned, other reasons for why we have more than 3 stools per day. We got laxatives, we got tube feeding. Chemotherapy, again, knocks out the GI tract's proliferation, knocks out anything that's proliferating fast, like the GI mucosa. And if your GI mucosa doesn't work, now we're back to square one, right? Just like inflammation of your mucosa makes the GI tract not work. Inflammation or irritation or the lack of GI mucosa can make it not work as well. So they get watery diarrhea as well. Immunosuppressants, right? Bowel disease, like Crohn's, ulcerative colitis can also cause a lot of diarrhea as well. Right? You might have some experienced nurses that say, I can smell C. diff from a mile away, right? Or they said, I can recognize C. diff. If you show it to me, show me 10 different stool samples, I'll tell you exactly which ones have C. diff, right? So they gathered 10 nurses. They took them to a stadium that Taylor Swift was playing, and they had them there, and they said, there were all these stools there. These just have really, really big noses, right? They had the biggest spectacles you ever saw, and they went there, and they told them to see if there's C. diff or not, and they failed, right? So they did 84 stool samples, right? And they found out it was just better than flip of the coin whether they got it right or not, right? They were only a 40 to 50% accurate in determining whether the color was equal to C. diff versus, and also the smell, right? So smell and color does not equal C. diff, right? Yes, when you have green stool, it might indicate it, but it doesn't always, right? When there is mucosal stool, or when there is liquid stool, or stool that smells sweet, like with C. diff, it's not guaranteed, right? 61% felt confident, but only 50% had 10 or more years experience, and no one performed better than chance that it was C. diff or not, right? So you can't trust that. If they have form stool, it's impossible to be C. diff. If it's liquid diarrhea stool, that's a good indication there might be C. diff present. We have to make sure we're looking at appropriate testing, as we know a lot of people have C. diff. So C. diff testing, when do we test somebody, right? Remember, if you do testing, we have very, very, very highly specific, like PCRs even, or toxin detection for C. diff that will detect the inactive C. diff as well. We want to detect active disease and treat active disease. All right, so C. diff testing, we got to make sure that it is, they got three or more stools. If it's less than 3 stools, like, we'll try again, right? So if you have 3 or more stools, then we will consider testing them, right? So they are on laxatives. Well, shoot, we're not doing testing if you're on laxatives, because that's the reason why you had 3 or more stools. So usually you hold laxatives for about 24 to 48 hours, depends on the protocol, all right? So I think over here we have at least 40 hours of holding, right? And then don't test patients that have an alternative explanation for it, okay? They have like tube feeding, laxatives, etc. Right? We don't test every like 3 days or 5 days to see that it's gone. We just test once and we're done. Oh, you got C. diff, and let's treat you for it, right? So don't test for a cure as well. And again, it's not based on the color or the smell of the stool. Okay, so what are some different tips, right? So again, it has to be a liquid stool. If it's not liquid, they're not going to test it, right? So they say medical grade medical grade stick, which is like a popsicle stick. So they stick a popsicle stick in the stool sample, and if it falls over, they're going to test it. If it stands, they're not going to test it, right? So if the stick stands, the test is banned. If the stick falls, test them all. Is a little mnemonic downstairs. Okay, if it ain't loose, it's of no use, is another trick as well, right? So that's a way we can get the C. diff order canceled, right? So they might order C. diff, but there's a lot of, not barriers, but a lot of checkpoints we have to go through to make sure that we aren't over testing for C. diff, because if we do, we're going to might even induce C. diff in the first place. All right, so how do you fix this, right? So we talked about all the testing. We're going to check laxative use, etc. But how do you fix this? Well, it's gram positive, gram negative. What is C. diff? It is gram positive, right? So it's your first episode of C. diff, right? And you have a gram positive C. diff bug. We're going to give something that annihilates gram positives. And what is that? That's our vancomycin, right? So vancomycin kills gram positives, and it's going to kill C. diff as well. Not IV vanco though, but PO vanco. So PO vanco is not absorbed by the GI tract. It's just like a topical cream, you could say, that you're going to swallow, and it's going to break apart, and then usually give it liquid form. And it's going to go down there, and it's going to eradicate the C. diff, right? It does not get absorbed. It's not nephrotoxic. It's not ototoxic. It's just PO vanco. It doesn't do anything except kill C. diff, right? We have a new guy on the block called fidaxomicin. Is an alternative, although it's more expensive. So that's another agent they can get that can control gram-positive bugs in the GI tract that will hopefully annihilate them. But we said that there's a 40 to 60% chance that they could get C. diff again. So it's the second time getting C. diff. What do? That's where we start giving what? You can give more PO vanco, but they're going to add on midazolam, or is that midazolam? that's not right. You don't give Versed. You're going to give Flagyl, metronidazole. I saw the A and the Z and the M. I just went to town. But anyways, metronidazole is going to be our next agent. And ironically, metronidazole, we had number 1, 2, and 3. Number 4 is metronidazole is the most common reason for C. diff development. So that's why it's going to use like a second line drug. But if they go, you got C. diff, your what's elevated, your white count is elevated, you got a fever. These are reasons to start more therapy. So we'll start PO vanco again, and then we give metronidazole to hopefully eradicate, right? Metronidazole is only for anaerobes. Are these anaerobes? Yes, they don't get a blood supply, right? They don't depend on the blood supply, right? You don't deliver blood to your GI tract, otherwise you have a GI bleed, right? So they just live in the lumen of the GI tract, which does not receive blood, and they are going to proliferate there as anaerobes. So metronidazole is great for that, right? If that doesn't work, they're going to keep coming back, and we're going to still keep starting the therapies, and they're going to say, you know what, I'm going to do anything to get rid of the C. diff. Anything you say. So we could give you a fecal microbiota transplant, right? So it pays very well, and just like blood transfusions and sperm donation, it pays very well to donate your stool to a stool bank, and they will then test the stool, make sure there's nothing infectious like CMV or Shigella or those other sexy bacteria that cause bloody diarrhea, and they will then donate it, and it will be donated, and they will then package it up and send it down to the hospital, and they'll say, here you go. Right? It's not delivered lunch trays. It's delivered, to the nurse, and the nurse will then inject it down in like an NG tube. It's much more palatable that way. And the other way to do it is also to get a colonoscopy, and they'll just donate it that way, and just donate it into the anterior or the right there by the appendix, by the what I'm trying to say, the proximal colon. Okay, so that's another option that we can do. And when you've gone through C. diff 3-4 times, you will ask for this too.
You go to the doctor to talk them into giving antibiotics for your coughing thing. They explain that the pain in your throat's a virus.
Antibiotics are not desirous.
But you ain't hearing this, you get all in their face.
Why, this is malpractice, a total disgrace. I'm not leaving this place without a script, my man.
Frustrated and berated, doc throws up his hands.
Day 1.
Zithromax pill on your tongue. Protect the bugs in your gut, killed off, son.
Day 8.
Your belly ain't feeling so great, and runny diarrhea straight ruins your days.
Fee, fi, fo, fum.
I smell the stench of Clostridium. Difficile colitis serves your rightus for wasting antibiotics on a virus. Now C. diff's free to grow, no competition. The spores that it sows, fecal oral transmission. In the ED, you're marinating, while your C. diff straight disseminate. Yo, now this ain't your run-of-the-mill type runs, cause the C. diff germs ain't fun. They're the ones with the toxins, fever, septic shock, and toxic megacolon. Yo, and the spores that they shed in the hospital bed ain't dead with Purell gel. What the hell? Use contact precautions, hand washings, hospital personnel. Yo, Dog MD just keeping it real with some loose smelly rhymes and an old school feel. Zombies creeping like Dawn of the Dead. C. diff seeping and spawning to spread. Use antibiotics as intended, and wash your hands now, docs, like you meant it. If you don't buy my advice, at least rent it. Hot mess in your shorts, prevent it.